Dear colleagues and friends, good morning. I would like to welcome you to the webinar Breast Radiology Innovation Course 2022. This is the second international online course of our society, the Hellenic Society of Breast Radiologists. Last year's course had about 600 participants. This year, we will focus on new biopsy techniques, contrast-enhanced mammography, and radiomics, how we use imaging as a tool for decision-making in breast cancer management, in diagnosis and treatment. 11 lectures in very interesting topics will be presented by experienced breast radiologists. This will last for 7 hours. In the middle of the program, there will be a bigger presentation by Professor Tabar on the applications of ABUS, automated breast ultrasound, in detection and diagnosis of breast cancer. I would like to thank all the international speakers for their participation. Dr. Grevenhold from Germany, Dr. Papalouka from UK, Professor Alcadara from Spain, Professor Mascheroni from Italy, Professor Tabar from Sweden, Professor Zouzos from Sweden, Professor Moschetta from Italy, as well as the Greek team speakers, presidents and commentators, the sponsors, and PRC Conference Office for contributing to this course. I wish you an effective attending day. We proceed now with the main program. It's my honor to present a friend, an expert on AI in mammography and DBT. First presenter will be Dr. Axel Grevenhold. Dr. Grevenhold is consultant radiologist and head of breast screening center in Paderborn, Germany. He was also involved in development of screen program in St. Gallen, Switzerland, and is co-chairman in the European Commission Guidelines Development Group for breast cancer. He has a special interest on AI, and he is the author of scientific papers on the implementation of AI systems in FFDM and DBT in screen and diagnosis. The title of his lecture is Real-Life Experience with AI as a Supportive Tool in Breast Cancer Screen Setting. The comments will come from Professor Kondos, breast surgeon in the University of Athens, and Dr. Hadjilira, breast radiologist. The time from the presentation is 20 minutes and the comments 10 minutes. I would like to ask you to keep the time. Please, Axel.
Hello, good morning, everybody. I will share my screen. Just a second. Okay, well, Nikos, thank you very much for having me here again this year. This time I would like to speak a little bit about my real-life experience with AI as a supportive tool in a breast cancer screening setting. I'm head of the mammography screening unit in Paderborn, which is part of the German screening organization. I will try to move my screen. This is my disclosure. Okay, I structured my presentation a little bit. First of all, I would like to give you an overview of the German screening program, then a product overview of the AI we are using. I will give you some preliminary study results of a study we're doing at the moment. I show you some cases and then I draw a final conclusion. The breast cancer screening in Germany, we have a population, we're inviting women between 50 and 69 years. They are all invited for 2D FFDM every 2 years. In Germany, at the moment, we have a participation rate between 50 and 60%. It dropped a little after COVID. We do use a double reading process, so 2 readers read the mammograms of each woman independently. And if one or both of the radiologists have a positive finding, the case goes to a consensus conference where all readers are discussing the case and decide on recall. Then the responsible physician is doing the assessment. The consensus rate, or the abnormal interpretation rate, is around 8 to 10% of all the cases that go to consensus conference. And then finally, we end up with a recall rate around 3 to 5%. That depends a little bit on if it's first round screening or subsequent round screening. The breast cancer detection rate overall is between 4 to 5 per 1,000 exams. The AI product we use is Profound AI by ICAT, and we use a detection tool for 2D FFDM. We also use a detection tool for 3D tomosynthesis. We use fairly new a risk tool, which gives you a risk estimation of the likelihood of being diagnosed with breast cancer within the next 2 years out of mammographic features. And we use a density assessment tool. I explain a little bit about the 2D and 3D detection tools. It gives you lesion scores right on the image, where a lesion score means a probability of a marked lesion to be a breast cancer. It also gives you K-scores, which is the probability of a complete mammography case to contain a cancer. I show you an example how it looks. On the image, you see lesion with a 57% probability of being a cancer. And on the right side, below that little window, you can see the case score of this case. So again, the lesion score is a calibrated lesion level 0 to 100% score for each location identified by AI. It represents the algorithm's confidence that the detection is malignant. And the case score again is a calibrated case level 0 to 100%, computed by aggregating information from all detections within the case, and it represents the algorithm's confidence that the case contains a malignancy. All cases will be assigned a score even if detections are not marked, if they are below marking level. Then we also use the density assessment and the risk tool. I show you the scorecard that comes with every mammogram in our unit. In the upper part, you can again see the K-score, 58% as an example. Then you see the density score, A. This is called A plus because it's a high A. And at the bottom, you see a risk score. In this case, it is an H for high risk of 1.43, and it is compared to the average risk at age 69, which is the woman's age, of 0.82. So she has a much higher risk of being diagnosed with breast cancer within the next 2 years. Well, what we have been doing for the last years is run a lot of studies to see how it works in real life. And this one, we did look at our experience in 2021. We integrated the use of AI as a supportive tool into our screen reading. In the end, 2 readers out of 5 chose to use it, 3 readers chose not to use it, which gave us the opportunity to look at the performances. The AI system was also used in consensus conference as a supportive tool or decision aid for recall. We calculated the results, and these are preliminary results. My friend Per Hall always calls it a quick and dirty analysis of sensitivity and specificity of the readers, and that was calculated on the detected cancers and compared within the single readers. We are not yet informed to false negatives, which will be interval cancers or larger subsequent round cancers due to lack of current information through cancer registry. We also calculated the individual breast cancer detection rate per 1,000 women screened for each reader and the overall breast cancer detection rate of the whole group. And then we looked at the abnormal interpretation rate or consensus rate, and that was calculated for the whole program. And we compared it to a large time period from 2009 to 2019 where AI was not in use. Now, the study period was the year 2021. We screened 18,956 women in our unit. We had 37,912 readings, and we compared it to the period 2009 to 2019, which is considered pre-AI. And in that group, there were 161,396 women screened, and we had 322,792 readings. I show you some results. On the left side, you see readers A, B, C, D. C and D were the ones who chose to use AI as a supportive tool. Now, pre-AI, their sensitivity was all pretty much the same. C and D were already a little bit performing a little bit better sensitivity-wise. Post-AI, that changed quite a bit. The readers increased their sensitivity by about around 3%. Specificity-wise, which is always the problem with using AI, because everybody thinks that the specificity will go down tremendously, it changed just a little bit. One of the readers with AI improved specificity and one decreased it a little bit. And then coming to the next column, it's the CDR, the cancer detection rate per 1,000 women. Pre-AI, we were all having around 4, 4.6, 4.8. It was pretty much the same among all readers, and the overall performance was 4.54. Then post-AI, you can see a tremendous increase by readers C and D. They have elevated it to 7.29 per 1,000 women and 6.97, which is really a very high number. All the others increased as well. That's probably due to consensus, because we also used AI in consensus. So the overall result was then 6.86 per 1,000 women detected. Regarding the abnormal interpretation rate or the consensus rate, pre-AI was 9.76%. Women who were sent to consensus conference, or images of women who were sent to consensus, and actually it dropped down after using AI. And recall rate increased a little bit to 3.29, but obviously we did recall the correct women when you look at the CDR. Now, to sum it up, readers with support of AI increased their sensitivity by 3.95% from 1.7 to 4.5%. Readers with support of AI decreased or increased their specificity by 0.35%, minus 1.1% to plus 0.4%. Readers with support of AI increased their CDR by 2.46 per 1,000, from 244 per 1,000 to 247 per 1,000. The AIR, or consensus rate, overall decreased by 2.46%. The recall rate overall increased by 0.32%. The cancer detection rate of the whole program, by adding 2 readers with AI, increased by 2.32 per 1,000 women, which sums up to a 51% increase in cancer detection rate. Now I would like to come to look at some cases. They were all screening exams. Women came with no symptoms because they were invited. They were dismissed by one reader, seen by another using the AI, and the consensus decision was always recall. I demonstrated on these cases because it makes most sense to see what readers missed and what AI could detect. Now, this is the first case. It's the original screening exam, dismissed by one reader. A second reader saw a lesion on the right side. These are the original images. And then when you look at the marked images with the AI, you can see a lesion at 12 o'clock in the right breast. A lesion score in the CC view was 94%. The lesion score in the oblique image was 33%. a K-score overall was 97%. And also we have the scorecard on the left bottom. It shows you that this woman had a high risk. The average at age 52 would be 0.51, and she had 1.31. We did a tomosynthesis and assessment, and there it is very clear. You can see a spiculated mass at 12 o'clock, and biopsy results were an IDC of 12 millimeter in diameter. Now, a second case, same history or same story, screening exam again, no symptoms, dismissed by one reader, seen by another using the AI. Consensus decision was a recall. This is the original screening exam. It's an ACR type B. It was dismissed by one reader. The second reader saw a lesion on the right side with the help of AI, and I show you the marked images. Here again, you can see a lesion with a lesion score in CC of 43%, a lesion score in OBL of 69%. The K-score was 80%. And she had a risk of 1.06, and the average would have been 0.9. When you do the tomosynthesis, which we always do in assessment, you can see the spiculated mass again, very small one, and the biopsy result was an IDC of 5 millimeters size. Third case is again the same story, screening exam, no symptoms, dismissed by one reader, seen by another using AI, and it was recalled after consensus. Again, this is the original screening exam. Not very much to see, ACR type B. And when you looked at the marked lesion, it gives you a lesion score on CC 75%, lesion score on OBL is 19%. This woman had a K-score of 85% and a very high risk score of 2.54 compared to the average at her age of 69 of 0.82. And in this case, because it was calcifications, we did a magnification, and you can see these tiny little calcification group here, and the vacuum biopsy results revealed a high-grade DCIS with micro invasion of 6 millimeters. So this woman would have probably been not detected for a long time because she was 69 years old already. And what we can see is it was well worth to detect that DCIS because there was already a micro invasion. Now, case 4 is a case outside of our study. It's just a very recent case, and it's a screening exam from 2022. There were no symptoms, and one reader dismissed it, and one reader suggested consensus. Consensus here was based on results from detection AI plus profound risk, and we decided for recall. We started using profound risk routinely only in 2022 as another supportive tool and an add-on to the detection. You can see the screening mammography here. It's a 69-year-old woman, no symptoms, no family history, and she has a lesion on the right side, which is clearly visible. Well, one reader thought it was a benign lesion because it's well-rounded, it's got sharp margins. And when you look at the lesion score in OBL and CC, they are not tremendously high. Neither is the K-score with 58%, which means pretty much 50-50. Density was measured as an A, and the risk was considered 1.43, which is very high compared to the age group. If we wouldn't have looked at risk, we would probably have dismissed the case because of the smooth margins and because of the rather low scores, K-score and lesion scores. We did a tomosynthesis then, and even in tomosynthesis, this looks pretty round, pretty nice margins. In the CC view, it looked like having a hilus, maybe an intramammary lymph node, but still the risk score of high interested us very much, and we performed an ultrasound in the end and saw the lesion that you can see on the right side of 6 millimeters size, and it was clip marked after biopsy, and the final results of the histopathology was a mucinous cancer of 6.7 millimeter in diameter, G1, ER positive, PR positive, HER2 negative, Ki67, 5%. So a case summary, we had rather low lesion and case scores in 2D FFDM, but also in the TOMO. The high risk and the risk assessment has led us to recall the woman despite rather low lesion scores and an overall medium K-score. Even in 3D, lesion scores and K-scores were not tremendously high. Without risk, this case would probably have been considered a BRIC 2 or maybe a BRIC 3. If we hadn't used risk as a decision aid for recall and a decision aid for biopsy after imaging this cancer would probably not have been detected within this screening round, but rather in the next round or the interval between being substantially larger. Now for this woman, the interval would have been endless because she was at the end of her screening age. Final conclusion from our study that I would like to draw. We are very sure now that by adding AI as a supportive tool to the reading process in breast cancer screening, more cancers can be found without really impacting the abnormal interpretation or consensus or even the recall rate. Because we did elevate the recall rate, but for the correct women, obviously because we detected more cancers. And we believe that an approach of single reading plus AI standalone and a consensus read of these results could be the future of mammography screening, at minimum for women with low K-scores and low risk assessed by AI products. And this is very important because we're facing a lack of radiologists everywhere in Europe and probably everywhere in the world. Thank you very much for having me here, and now I'm open for a discussion.
Thank you, Dr. Grevenhold, from your great lecture. We're open for comments now. First, Professor Kondos, would like to have your comments, Mihaly.
Thank you and good morning to everyone. First, I'd like to thank Dr. Dimitropoulos for his kind invitation. Thank you, Nikos. It's always a window to the future, these webinars of yours, and thank you. And I would like to thank thank you for the opportunity to make a comment on this, on the talk of Dr. Grevenhold. As I said, I am a clinician, I'm a surgeon, so I will speak from that point of view, from the point of view of a surgeon. Clearly, AI is here to stay, but still it is early days. And that's why we have a lot of questions and we haven't quite found yet the perfect way to use this tool. Having real world data, I was not aware of the data Axel presented to us today. I was not aware. Real world data are useful because they will give answers to questions that smaller studies cannot. So let me start. I have only 4 points, so less than 1 or 2 minutes. First of all, what we don't know, and we're hoping that we will, is the setting in which AI should be used. I noticed in your talk, Axel, that in the study you presented, you said that some of the, or two of the radiologists chose to use AI. So it's not necessary for them to use. It's not obligatory for them to use. You can choose to use it, or you can choose to not to use it. Which means that we don't know how to use it. We don't know whether we will have a double red screening mammography plus the AI, or we are aiming to eliminate the one radiologist and replace him with AI, or in the future, do it without any radiologist. I'm not sure. This is not the close future, apparently. So we don't know how to use it. Second is we don't know on what images we should use it. Should we use it on the normal routine digital mammography to DEM, or should we use it on tomosynthetic mammography? We don't know it yet. And by the way, comparing today's results with 10 years ago results, so AI today with radiologists 10 years ago, is not, I think, is not a clear, is not fair, is not a clear comparison, because the quality of images we get now is so much better than 10 years ago. So this improvement in cancer detection can be because of the quality of images, not only because of AIs. Second, what we don't know yet is the sensitivity threshold we should use. In my mind, and you mentioned it, Axel, in my mind, the higher the sensitivity threshold is, the more sensitive the test becomes, but the less specific becomes. You said, according to your findings, that yes, the sensitivity perhaps, the specificity does not drop as much. In my mind, this is very important. This is very, very important. And the other thing is that the recall rate, you know, I'm thinking that we're saving money by perhaps using new technology. We want to save money, but if you call back a lot, many patients to the hospital for extra tests, extra biopsies, extra MRIs, etc., the money just shift from one big bucket to another. So it's not saving money. Then I'm just wondering, this is my third point now, I'm just wondering that using all this very modern imaging and very modern AI, enable us to find cancers that are not clinically important. I know there's no answer for that yet. We know that 2 per 1,000 screen detected cancers could potentially be left there to be discovered a year later and no harm done. So I'm not sure about the biology of these new cancers. You said that you found a high-grade DCIS with microinvasion. This is what we want to find. But this was just one case. I wonder what the big picture is. And finally, we need training. I mean, radiologists need training. Every new tool and every new equipment we use, we need to be able to use it in the correct way. So training is important. These were kind of comments and questions. I don't know if anyone or Axel wants to answer, or
Yes,
anybody
please.
else perhaps.
Axel.
Yeah, I would like to answer that. First of all, about image quality. Well, we've been using the same machines for years now. We need new ones, but in a screening program, you know, it's always about investment. So the comparison between the period of 2021 and 2009 to 2019 is pretty fair, because most of the time we really did use the same machines. Secondly, I'm not a believer in AI standalone at the moment. I think it's much too early, because when you would run these cases, which we actually did, but I didn't show the cases, you would find a very high sensitivity, of course, but you would have a tremendously lower specificity with an algorithm by itself. So our approach was to say, okay, use it like a magnifying glass, use it like a supportive tool. just to show you detections, maybe when you're not aware of something, maybe when you're disturbed by something, because we are reading 200-300 mammograms a day sometimes, and you get tired, you get disturbed. And if something shows you lesions that you're supposed to look at, that will help you. And that's what you can clearly see. The ones that were helped by the algorithm were performing better. It is quite difficult to speak about overdiagnosis. We're in the process of working up all the cancers, but we can see that we are not detecting tremendously more DCIS than invasive cancers. So the ratio between DCIS and invasive cancers is pretty much the same across all the radiologists, except what you can see is a slight difference in size. The ones that used the AI as a supportive tool saw smaller cancers. But of course, there is an issue of overdiagnosis with every exam with every supplement you add to screening. That's for sure. But in my opinion, as a radiologist, it's my job to detect as many cancers as I can. As long as the pathologist cannot tell me this one kills a woman and this one doesn't, I have to detect all of them.
I agree that there's no over-detection, over-diagnosis, over-treatment. I agree with that.
What about comments from Dr. Hadzilira?
I would like to thank you also, Nikos, for inviting me to speak, and Mr. Grevenhold for delivering this interesting speech. I would like to sum up that the goal for everybody involved is the patient. And in that perspective, every weapon that gives us the chance to find early diagnosis and detection of breast cancer is welcome. I have not seen this current use of risk model in studies as yet. Maybe it hasn't been published yet, and that was one of the points that I would have made. These are some factors that seriously affect human radiology performance, like the ability to compare prior and contralateral exams, the risk stratification that involves including information about personal and family history. These, as yet, are not included in the AI algorithms, and we should try to do that. Personally, I can, as a radiologist, I cannot arbitrate the use of AI alone. Most studies invite, I propose to obviate the need for a second radiologist, because the shortage of radiologists globally is an issue, or is going to be an issue really soon. And I think using AI is a way to overcome this shortage, at least in breast cancer screening. And trusting AI would be a challenge for patients and radiologists as well. It changes doctor-patient relationships. For example, it's not an easy thing to say to a woman that AI detected your cancer. There has to be a doctor involved, because that is what gives a woman or a patient confidence in the diagnosis. Also, I would like to ask you some questions. What about the radiologist bias when you use AI? When do you present your AI results? If, for example, you use, there is a proposition to use AI in triaging negative mammograms. That would relieve at least, they say, at least 30–40% of the workload in a screening program. What about the rest of the mammograms? How would a radiologist perform in this setting, knowing that these are the exams that the AI has not labeled as normal. When should the AI outputs be presented? What we need to evaluate different user interfaces. How are we going to present it? They are going to work independently, they're going to work together.
A small answer from Dr. Grevihol, because we have to go on.
Well,
And I would like to end this by saying that actual clinical experience does not always live up to expectations. We saw CAD rising and falling, and we need more prospective trials. For example, have you used your algorithm in several populations, like women with implants with prior history of breast cancer? These are not as yet implemented. Can we use it with different vendors? These are problems that are going to be found. We as radiologists should see the future of AI in radiology. We should embrace it. We should educate ourselves and become the experts in AI technology so that we help shape the technology and use it for our interests. This is not a battle between human radiology and AI. This is the future.
A small answer, Axel.
Well, a lot of thank you for that comment. A lot of things that you address now, we have evaluated, but I can't give you all the results of the study right now. We will write a publication about that pretty soon. But I agree completely. I don't see AI standalone yet. I think there is still some time to go. We were very lucky, actually, that we could do this retrospective evaluation of a really prospective trial, because we chose to use it in clinical practice, and we also had readers who didn't want to use it. So we could compare pretty well in real life, and I think that's the sweet spot of this study we did, because usually you compare reading in a screening program with reading AI standalone, and this is not what's going to happen. I don't think it's going to happen soon, because that would elevate the recall rates tremendously. But we could prove that we didn't elevate the recall rates tremendously, only a little bit, but for finding more cancers. And then this shows us we recalled the correct women. So I think there is still a lot to do. And of course, even though it's large numbers, it's still small numbers, considering that screening programs impact on millions of women. So, but this is what we could do, and that was for our assurance also to use it.
So have to go on. Thank you, Axel, for being here with us.
Thank you.
It's always a pleasure to have you with us. Thank you,
Thank you very much.
Pandos. And Tula, you go on. You are the president of the next lecture.
Looking forward for the publication.
Thank you.
A lot of job to do, Axel. The future. Thank you. Bye-bye.
Thank you.
Bye.
Tula, go on.
Just give me a moment. I would like to present the next presentation. Is Dr. Eiro Mukturi, a dear friend. Just give me a moment, please. She's a consultant breast radiologist, the head of breast imaging department and Reginald's Hospital, Athens, Greece, for the last 5 years. She has worked as a breast consultant in private sector for many years in Athens. She has a Bachelor of Medicine at University of London, Imperial College of Science in London, United Kingdom, and radiology specialty at Icon Hospital, University Athens. The title of her presentation is DCIS Imaging and Signs of Aggressiveness. Commentators would be Professor Keramopoulos, who is a gynecologist and breast surgeon, and Dr. Papadoniou, who is a breast radiologist. The time for the presentation is 20 minutes, and for the comments 10 minutes. I would like you to ask to keep the time. We proceed Iro, my friend.
Good morning, Douglas. Good morning, everybody. My name is Iro Mufturi, and I would like to thank you very much for your kind invitation for me to participate in this day conference to talk about the DCIS imaging and the signs indicative of aggressiveness. So just a quick word, what is a ductal carcinoma in situ? It's the earliest cancer in the breast ducts. It's a type of stage 0 breast cancer. Usually is benign, but it can progress to invasive breast cancer if left untreated. Usually half of it does. There are two main subtypes, the comedo subtype, which is the more aggressive one, and the non-comedo type, which is the less aggressive one. Most are asymptomatic. Some come with palpable findings, either by the patient or the doctor, and some have nipple-related disease, like the Pazet disease of the nipple. The main risk factors of death following DCIS diagnosis is the early age of diagnosis, a Black ethnicity, and having a second primary trilateral invasive cancer. Here's an example of a woman that came for her first mammogram prior to a breast augmentation operation. And we saw these calcifications that after the spot compression view, you can see that they're slightly pleomorphic, some of them are linear, they have a linear direction towards the nipple, and obviously we thought that it was a DCIS. So we did an ultrasound scan to see if we can see something there. Normally, a lot of the time we don't see anything there, but in this case, we saw a hypoechoic lesion with a slightly lobular edge and increased blood flow in the periphery. That prompted us to actually biopsy after doing a breast MRI scan first, which showed nothing. We had no enhancement in the breast at all. So after the biopsy, it was proven to be a DCIS. And here, just a quick reminder of the ductal carcinoma stages. Stage 0 is the DCIS that we talked about before, and the rest are the invasive stages of cancer. There's stage 1 to 4, with the largest one is stage 4 with invasion and metastasis to the lymph nodes, to the bones, to the lung, to the brain, and liver. How do you do the diagnosis for the DCIS? How do you make it? Well, the tools are mainly the mammography and the tomosynthesis. Also, you've got the ultrasound scan, you may have a breast MRI, and you can have obviously the examination if the examiner palpates something, and then we examine it, and if needed, we can biopsy normally through ultrasound, and it depends on the findings, obviously. So in this case, we've got a high density lesion in the 11 o'clock area of the left breast, which has some calcification too. In the ultrasound scan, it looks as a hypoechoic irregular lesion with a vertical direction. And in the breast MRI scan, it looks like hyper-enhancing, slightly irregular lesion that after biopsy was proven to be a DCIS. Here's another lesion. It's a 12 o'clock lesion of the right breast with more irregular borders, as you can see. It's spiculated, and it looks in the mammogram more suspicious than the previous ones. And in the ultrasound scan, it looks like hypoechoic, slightly lobular lesion. While in the breast MRI, you've got a lobulated hyper-enhancing mass lesion that after biopsy was proven to be a DCIS. And after excision, there were some signs of invasion. So let's talk about a bit about mammography and tomosynthesis. What do we normally see in mammography and tomosynthesis? A lot of the times you see casting type calcifications. You can have pleomorphic calcifications, you can have linear calcifications, which are more likely related to the comedo type. There's a higher risk for invasive DC with fine linear branching morphology. And also if you have calcifications that are regional or with diffuse distribution, they're less likely to be invasive or related to cancer. If you have granular calcifications, they're more likely to be related to the non-chromidio type. And you always have to keep in mind that there's a discrepancy between the distribution of the disease seen in the mammogram and the one seen in the breast specimen, because not all DCIS calcified. So you may think you've taken out all the disease, all the calcifications from the breast, but there still might be the disease left behind because it's not calcified and you can't see it. Calcified DCIS can be more aggressive than the non-calcified DCIS, and usually is. It's unknown whether non-calcified DCIS progresses to invasion of surrounding tissue less frequently than non-calcified DCIS, calcified DCIS, excuse me. Here we've got some pictures of a low-grade DCIS on the left and a high-grade DCIS on the right. Let's focus on the differences. On the left, these classifications pretty much look like the ones that we saw in the beginning. Linear direction towards the nipple, pretty much equal densities, slight pleomorphism, and they were proven to be a low-grade DCIS. But on the other side, you've got the high-grade DCIS, you've got the fine linear branching pattern, there's more pleomorphism and greater discrepancy in the density. And you can see they go in different directions, they're branching. And it just looks, as I say, more angry, and obviously it was of a higher grade DCIS. In this case, we've got calcifications, groupings of calcifications that we were checking for a few years, maybe 2-3 years. They had not changed all this time, and because it didn't look that suspicious, we hadn't actually decided to take them out and examine them. But she did a breast MRI scan which showed peculiar enhancements, so we decided to place hookments, make multiple hook placements and examine them, and they were proven to be a DCIS after excision. So you don't just have calcifications in the mammography and tomosynthesis. You can have soft tissue mass opacities with or without calcifications. You can have masses which can have irregular shapes and indistinct borders. You can have asymmetries or even architectural distortions. And you can have lesions without calcification about 10 to 20% of the time. The clinical symptoms are more often in women with the non-calcified DCIS. Here in the inner quadrant of the left breast, you can see an architectural distortion, more obvious in the spot compression view, that after excision was proven to be a DCIS. So what else can we use? We can use the ultrasound scan. And how does it look in the ultrasound scan, the lesion, the DCIS? It's usually microlobulated hypoechoic mass lesions. There could be duct extension, in which case you have to try and biopsy because it's a worrying sign. It could actually look hypoechoic with well-defined lesions, with well-defined borders. It could actually look like a fibroadenoma. You can have lesions that are very irregular in borders, and they're usually more infiltrating than the ones that have well-defined borders. And they can have even cystic and solid components to them. We can see sometimes architectural distortions is usually more difficult to find in the ultrasound scan than in the mammogram, but you can see it with experience. And sometimes you see minute calcification in the ducts. And also if there's high blood flow in the ultrasound scan, then you are more likely to have an infiltrating cancer. And if there's increased stiffness of the mass in the surrounding tissue, there's increased tumor grade. And last, you should always biopsy. If you biopsy, you do it through the ultrasound scan. If you can see the lesion through the ultrasound scan, it's easier and quickest and cheapest to do it that way. So we usually perform the biopsies through the ultrasound, but it depends on whether the finding is something that we can see in the ultrasound scan. But here's just some pictures to show you. The upper two pictures showing you the duct dilatations with the calcifications, which is a sign that if you actually see it, you should probably biopsy, because it's probably a DCIS, which was proven to be the case in this case. The other lesion at the bottom, the third lesion here, there is an ill-defined lesion. You can't see the borders really. And it was proven to be, it's usually more aggressive looking. So if you see something like that, you normally don't think it's a DCIS. And it was proven not to be a DCIS with some signs of invasion. It was proven to be an IDC. So you have to think that sometimes a DCIS may not be able to be seen in the mammogram, and it's only detected in the ultrasound scan alone. And if that's the case, then it's usually lower in grade than the calcified DCIS. There's a superior rate of detection of the non-calcified DCIS with tomosynthesis and ultrasound than the mammogram alone, meaning that in the dense breast, it's a good thing to use tomosynthesis in the ultrasound scan, because you can catch more lesions than just the mammogram alone. Here's a hypoechoic, slightly cystic looking lesion with lobulated borders. That was proven to be a DCIS after biopsy. So what does it look like in the breast MRI? In most cases, it has a clamped non-mass enhancement appearance. It could be either segmental or linear in distribution with variable kinetics. You can have clamped or heterogeneous enhancements. You can have ring enhancements, which is most specific for DCIS. Also, you can see discrete masses or small focus. And there's usually no significant differences between the calcified and non-calcified DCIS in terms of morphology and enhancement characteristics. And the DCIS that presents as a mass or a foci is usually lower in grade than the non-mass enhancements. So if you have non-mass enhancement, you think that it's more advanced in stage. Here's some pictures to show you a DCIS. In the upper quadrant of the right breast, there is an early enhancing lobular lesion that was proven to be a DCIS. On the other picture here, you've got a small, well-defined focus in the lower quadrant of the breast that, if you just saw it without having any guidance and any look at the mammogram or the ultrasound, you wouldn't say anything about it because it looks benign. It has good borders, well-defined borders. When we saw the mammogram, there was a grouping of calcifications there, which is why we actually examined the area. And after taking the calcifications out, it was proven to be a DCIS. Here's another presentation of a DCIS. You've got a linear enhancement near the nipple, along the duct. It's quite often to present like that. And also another one that's quite often too, more advanced in comparison, obviously. The irregular enhancement is in a segmental region distribution of the lower quadrant of the breast. That was proven to be a DCIS with high-grade DCIS. So just a few words about the invasive ductal carcinoma. It's usually isointensity T1 and T2, and it could be hypointensity T2, and have a hyperintense edematous zone. After enhancements, you can have irregular spiculated lesions or even ring enhancements and dilating, draining veins. Also, you can have a non-mass enhancement, as we said before, and various kinetics. This is a picture of an invasive ductal carcinoma. Got coalescing microlobular lesions, enhancing lesions, typical of cobblestone appearance. That was proven to be an invasive DC. a few more examples here. In the upper outer quadrant of the right breast, we've got coalescing ring enhancing lesions with ill-defined borders that were proven to be a multifocal DCAS. Here, that's what it looks like in the ultrasound scan. Hyperechoic ill-defined lesions in a vertical direction. This is another ring-like lesion at the 6 o'clock area of the left breast that was proven to be a DCIS. Another ring-like enhancing lesion at the outer quadrant of the right breast with quite well-defined borders that was proven to be a high-grade DCAS. And on the other picture here, we've got an early enhancing spiculated lesion that looks more angry and looks more suspicious, obviously, than the previous one. That was proven to be an invasive DC. So, will the DCS become infiltrating? We cannot predict with certainty which presentation of the DCAS will be more aggressive and spread. Certain types of breast cancer can grow at faster rates, like the triple-negative breast cancer and the HER2-positive breast cancer. Some low-grade DCAS may never become invasive, so we can't really call on all the groupings of calcifications as BRCA4 lesions and biopsy them all, because there's a risk of overdiagnosis. We have to find a way to choose which to call BRCA4 lesions. We have to bear in mind that up to 11% of the DCAS may have an aggressive component at the time of biopsy, and 20 to 25% of the DCAS on biopsy may have an invasive component following surgical excision. So in conclusion, if we have a new inconclusive irregular finding, we should always biopsy. If we have a new not suspicious solid finding in a woman with positive family history, we should consider the biopsy and maybe a breast MRI. And if you've got a new not suspicious finding in a young woman with no family history, we should consider a breast MRI and if no pathological finding, either a close follow-up or consider biopsy. So thank you very much.
Turla, we move to the comments.
Sorry, thank you, Iro, for your beautiful presentation. I would like to call the commentators for their comments, Mr. Keramopoulos and Dr. Papadoniou.
Thank you very much for this wonderful talk. I'm a radiologist, breast radiologist, and the most important thing for us, and with this speech, is to say that we must have all the modalities in our hands and try to diagnose from the beginning to the top with mammography, with ultrasound, and with MRI, and with biopsy, and to do it all by ourselves, so that we can perform better. As it was previously told, we can't predict which is more aggressive or not. So we must try to find all the cancers. Sometimes we are overdiagnosing, yes, but it's difficult to leave it. That's a very big issue for us radiologists and for breast surgeons. And in Greece, we should be more, we should try and have breast imaging centers And it's for us radiologists to do this. That's my comment on this speech.
Thank you, Pandora Papandoniou, and I would like to call Professor Keramopoulos. Professor Keramopoulos.
He was here before, maybe the connection was lost.
Okay, I would like to ask Tiro a question. What's your strategy when you find a DCIS? Do you perform usually MRI?
Well, in general, when we have a positive biopsy, we do perform MRI scans because of the increased risk of having multifocal, multicentric diseases.
Yeah.
And it usually is more aggressive if you have a multifocal disease, and the outcome of the patient is worse than if you have a unifocal lesion. So apart from finding the other lesions that we said before, it can help the surgeon as well perform a better operation, a better surgical plan. And also with extensive disease, we can see how the chemotherapy the patient can have before looks, how much it works in comparison to the one you can have after taking the chemotherapy, and follow with greater precision in cases that you have a chemotherapy plan before operation.
Here in Cyprus, we're very fortunate in that because we usually perform MRI prior to surgery, and we can see sometimes aggressive and invasive components of DCIS or other disease related to breast that changes the surgical plan, and that's the message. Does Professor Keramopoulos, he's not able to connect, maybe.
And just the last thing, also, in order to be ethically correct, as the science has progressed, one must try and use the technology available when needed to improve the overall outcome of the patient. So why not use it?
Yes, and as far as our diagnosis is concerned, I would like to ask Dr. Papandoniou. She said that already, of course, that I don't know if finding low-grade DCIS is actually overdiagnosis. We don't know whether this will progress to a more aggressive disease. So we're obviously, as radiologists, committed to finding early breast cancer. This is the goal of everybody. So I don't see this as an overdiagnosis. We don't know if this DCIS would eventually kill the patients.
Yes, and this must stop. The topic of overdiagnosis must stop. We don't know if it's going to progress. So we're committed to say that we see something and we must biopsy. This is the topic.
Yes, this, and we don't know if finding DCIS at early stage saves women from finding invasive cancers in the next screening round or the next to next. This is a very difficult issue. We are pushed not to overdiagnose, but if we find DCIS, we must remove it. This is the case now. Thank you very much all for your presentations.
Thank you.
Dr. Papandoniou, and I give the speaker to Dr. Daukopoulos for the next speech. Thank you very much.
Thank you.
Thank you too.
Thank you.
Morning. I'm Stefanos Daukopoulos, breast radiologist. I thank the Hellenic Society of Breast Radiologists and the President, Dr. Dimitropoulos, for the kind invitation to be part of this webinar. Next presenter is Dr. Vretou, Anna. Dr. Vretou is consultant breast radiologist in Metropolitan Hospital, Athens, Greece, He had a master's degree in breast oncology from Istituto Tumori, Milano, Italy, and has worked in private sector breast centers for many years in Athens, with a lot of experience in the diagnostic approach to breast pathology. The title of her presentation is Breast Imaging and Lesion Management in Pregnancy and Lactation. Commentators will be Dr. Louvreau, gynecologist, breast surgeon, and Dr. Tsipapadakis, breast surgeon. The time for the presentation is 20 minutes, and for the comments, 10 minutes each. I would like to ask you to keep the time. I would ask Dr. Bretou to take over with her presentation.
Good morning, dear colleagues. I would like to thank Dr. Dimitropoulos for the invitation. I'm going to present breast imaging and lesion management in pregnancy and lactation. Breast is a typical organ that is influenced by hormones from menarche until menopause. During pregnancy and lactation, a woman's breast faces several physiological changes. It is influenced by estrogens, progesterone, prolactin, and oxytocin. Particularly by the influence of estrogen, the blood vessels show remarkable growth and lobules are proliferated. In the meantime, fibrolipoma substrate decreases and blood flow increases. During the second and the third period of pregnancy, the proliferation of lobules and the decrease of fibrolipoma become more intense. In a period of lactation, due to drastic reduction of estrogen and progesterone, prolactin levels increase and the alveolar cells produce milk by taking up nutrients from the blood. The two main actions of oxytocin in the body are the contraction of the uterine muscles and the secretion of breast milk. It takes 3 months after cessation of breastfeeding in order for the breast to return to pre-pregnancy state. The diagnosis of breast disease during pregnancy and lactation is difficult. And why it is difficult? Because the breast volume increases, the water content increases, and we observe much more firmness and palpable nodularity. The parenchymal density also increases. In this image, you can see to left a mediolateral oblique mammogram view of the same person, performed 2 years apart. Prior to pregnancy, the left image, and during lactation, the right image. In this slide, we can see almost all the breast disorders related to pregnancy and lactation. I'm going to read some of them. Benign disorders closely related to physiologic changes, gestational and secretory hyperplasia, spontaneous blood-enabled discharge, galactosile, gigantomastia, puerperal mastitis, benign tumors that including the lactating adenoma, and of course, malignant tumors that include PAB, pregnancy-associated breast cancer. It is important to note that most breast lesions that are diagnosed during pregnancy and lactation are benign, thank God. The most common benign lesions are galactosile, puerperal mastitis, fibroadenoma, fibrocystic changes, and abscess. The ultrasound is the examination of choice in the workup of a palpable mass in a pregnant or lactating patient. All patients with a dominant palpable breast mass that persists for 2 weeks should be evaluated with an ultrasound examination. The advantages of ultrasound include safety, due to its lack of radiation. Furthermore, it's easily performed and the patient feels comfortable. It has also a high sensitivity in the detection of pregnancy-associated breast cancer, and it can detect the most benign lesions. Any suspicious findings observed on ultrasound can be properly evaluated with ultrasound-guided core needle biopsy or fine needle aspiration. It is also very helpful during neoadjuvant chemotherapy. I'm going to remind the ultrasound suspicious findings, the irregular shape, unsharp contour, the angular margins, a mass that is taller than wide, the speculation, the branch pattern, the microlobulations, the calcifications, the ones that do not produce shadow, the marked hypoechogenicity, the acoustic shadowing, and the thick echogenic halo. This is the edema that some tumors produce. Maybe sometimes we can see that the tumor is very, very small and we can see only a black in the middle, but around we have a great area hyperechoic, and this is the edema that some tumors produce. So let's talk about some of the most common benign lesions. Galactocele. Galactoceles have been described as cystically dilated terminal ducts and terminal ductules that are filled with milk. The classical clinical history of galactocele is a painless lump that appears during breastfeeding or even during the third trimester of pregnancy. The sonographic appearance of the galactocele varies with the stage of development of the galactocele and with the location. Fresh milk is nearly anechoic. Galactoceles tend to become mildly to moderately echogenic as they age. The lipid components in older galactoceles become less well emulsified and coalesce into larger fat globules. The location of galactoceles can affect the appearance. Peripheral galactoceles are often multilocular. Centrally located galactoceles appear unilocular or bilocular. Acute galactoceles are anechoic or simply cystic. In subacute galactoceles, the trapped milk tends to become echogenic because the lipid contents become less emulsified, forming larger droplets of suspended lipids. In chronic galactoceles, enzymatic action denatures the protein components of milk, causing the milk to become mildly hyperechoic. In such cases, the galactoceles can appear to be solid and hyperechoic and may be difficult to distinguish from surrounding glandular tissue. And now some images. Here we can see a peripheral galactocele that appears multilocular. And here a central galactocele that it is unilocular. Here we can see an acute galactocele, and here a subacute galactocele, and in this image, chronic galactocele. Most galactoceles regress spontaneously over a few days to weeks. In this case, this galactocele gradually regressed over 4 weeks. Another very common benign lesion is lactational mastitis. Mastitis is inflammation of the breast that may be either infectious or non-infectious. Infectious mastitis most commonly is acute, occurs during lactation, and may progress to tissue necrosis and abscess formation. Nipple fissure is an important condition allowing skin bacteria, Staphylococcus aureus, to penetrate through the skin into the ducts. Patients with acute puerperal mastitis have localized or diffused edema and erythema of the breast, along with pain, tenderness, warmth, and fever. But lactational mastitis doesn't have only clinical findings, has also sonographic findings. In the right side, we can see the breast that is affected with puerperal mastitis. The left side is unaffected. We see that the edema of subcutaneous fat causes the fat to be hyperechoic. This you can see in the middle of the right image. The skin becomes thick and mildly hyperechoic. You can observe that on the top of the right image. The Cooper's ligaments are also thickened and become less echogenic. The edema affects all the tissue layers in the area of inflammation. And here we can see an abscess. So let's go now to the management. What we do. If a woman feels a lump that persists more than 2 weeks, then she should perform an ultrasound. If the ultrasound shows any suspicious findings, then she should do core biopsy or FNA, but especially core biopsy. And if the core biopsy results positive for malignancy, then we should think the possibility of the mammography. Mammography is generally safe during pregnancy and lactation. The radiation dose from bilateral to digital mammography studies is less than 3 mg. The estimated dose to the uterus is less than 0.03 mg, which is exponentially less than the 50 mg, below which no known teratogenic effects have been reported. Late apron silver decreases the dose to the uterus up to 50%. If a patient happens to undergo mammography before she is aware of her pregnancy status, she should be assured by her doctor that the risk to the early fetus is very minimal. Despite the relative safety of mammography during pregnancy and lactation, mammography is recommended only if an underlying malignancy is suspected and has been proven by core needle biopsy. The sensitivity of mammography in detecting pregnancy-associated breast cancer is less. The diminished sensitivity of mammography is likely secondary to increased parenchymal density due to hormonal changes that occur during pregnancy and lactation. However, mammography may be useful in the detection of suspicious microcalcifications not seen on ultrasound examination and in the determination, in this case, of the extent of the disease, including multicentric and contralateral disease. Lactating patients are asked to nurse or pump immediately before undergoing mammography to decrease parenchymal density related to retained milk products as much as possible. Routine annual screening mammography is not performed during pregnancy. In women older than 40 years old, mammography screening should resume approximately 3 months after cessation of lactation to allow the breast to return to baseline density. Contrast-enhanced magnetic resonance is not recommended during pregnancy because gadolinium may have teratogenic effects in humans. Although there are no reports of teratogenic effects in humans, there are also no prospective control studies evaluating the effects on the fetus. In lactating patients with newly diagnosed breast cancer, MRI contrast enhanced may be selected to evaluate the extent of the disease. Women undergoing MRI should also be recommended to nurse or pump immediately before the exam. Nevertheless, it should be noted that increased enhancement from hypervascularity may pose difficulties differentiating lactational changes from suspicious findings. The amount of gadolinium extracted into the breast milk is minimal. However, if the patient desires to avoid any ingestion of gadolinium by the infant, breast milk should be pumped and discarded for 24 hours after the administration of gadolinium. Given the negligible extractive of gadolinium in the milk, the American College of Radiology guidelines do not require that patients discontinue breastfeeding. The diagnosis with breast MRI evaluate the extent of the disease, the multicentricity, the multifocality, evaluate the subaerial area, the infiltration of the skin, and infiltration of pectoral muscle. About imaging-guided procedures, cord needle biopsy is the procedure of choice because of its lack of radiation and quite ease of performance. The local anesthesia with lidocaine is safe for the fetus. After biopsy, blood and lidocaine can be found in the milk. MRI-guided procedures can be performed in lactating patients. And now let's talk about the cancer, about PAD. Pregnancy-associated breast cancer is the most common malignancy of pregnancy, occurring in 1 in 3,000 to 1 in 10,000 pregnancies, and is the most common cause of cancer-related death in the pregnant and lactating. The average age of diagnosis is estimated at about 35 years old. The incidence of pregnancy-associated breast cancer is expected to increase as more women delay childbearing. The clinical findings. Most often, we have a palpable, planeless mass, less often a unilateral breast enlargement with skin thickening, focal pain, and nipple discharge. Cases of milk rejection have been reported. And this is really very, very interesting. The infant refuses to nurse from the affected side. Sonographic findings: a mass with indistinct margins, increased posterior acoustic enhancement, and cystic necrotic areas. Here we can see cancer in a woman that she was in her 5th month of pregnancy. How about the histopathology of these cancers? They're usually high-grade invasive ductal carcinoma. They are estrogen receptor negative, progesterone receptor negative. They have a high-rate lymphovascular invasion. They're HER2 positive, and they present P67. The imaging features of PAP have been reported to be similar to those of non-gestational breast cancer. The difference is that PAP has a poorer prognosis, and more than 50% are high-grade tumors caused by a delayed diagnosis. Most breast cancer are not diagnosed until the postpartum period, despite the fact that patients sometimes show clinical symptoms during pregnancy. And why do we have a late diagnosis? We have a late diagnosis because the mammary gland undergoes clinical and radiology changes during pregnancy and lactation, which make diagnosis more difficult. We have underestimation of clinical findings, denial of the patient. Many women, they can feel a lump but choose to ignore it. And because women in this period perform fewer examinations. So the conclusion about this cancer is the incidence is increased. The ultrasound is the examination of choice. In case of suspicious findings, then we should perform biopsy. Mammography only, and in some cases of malignancy, and MRI only in lactation. The most crucial issue for the radiologists is to avoid the late diagnosis of breast cancer. And in this image, you can see a painting titled Madonna and Child by Jean Fouquet. Thank you all very, very much.
Thank you, Dr. Bretou, for your excellent and thorough presentation, and that you were just in time. Now we'll be proceeding to our commentators, beginning with Dr. Louvreau. I would like Dr. Louvreau to make a comment. Dr. Louvreau.
Καλημέρα.
Good morning.
Καλημέρα. Good morning.
Ευχαριστώ για την πρόσκληση. Very good speeches, Mrs. Bretou. I agree with you, but I have to tell something. I propose to all obstetricians examine the pregnant women during the pregnancy and the lactation every 3 months. The breast cancer is very small incidence, but we can lose the women. We have problems to diagnosis because of the changes who happens during the pregnancy and the lactation. So women diagnosed with breast cancer during pregnancy often present with an advanced tumor stage and axillary lymph node involvement. I agree with you that palpable masses persisting more than 2 weeks should be investigated even if the ultrasound or mammo are non-diagnostic. But we have always to remember that 8% of breast biopsies during pregnancy will be benign. So I think that to have close during the women, during the pregnancy, the obstetrician is a good idea, and also don't forget to do ultrasound. And another thing that I have to tell you is that as women delay childbearing, the incidence of breast cancer with pregnancy is probably to increase, because the risk, we don't forget that the risk of breast cancer increases with age. And also women with a strong family history had a significantly high risk of postpartum breast cancer. Thank you for all.
Thank you, Dr. Louvro. I would ask Dr. Xipapadakis to make a comment now.
Hello. Unfortunately, Mr. Xipapadakis had an emergency to attend to. On behalf, I would like to thank you for your very interesting and enlightening presentation. Pregnancy-associated breast cancer is a very important phenomenon, and considering a trend towards childbearing at more advanced stages, the incidence of pregnancy-associated breast cancer is expected to further increase. And as you pointed out, imaging and management of breast lesions during pregnancy and lactation has been a very nebulous topic, as the physiologic changes of pregnancy pose unique challenges for the obstetrician, breast surgeon, and radiologist, which may contribute to a delay in diagnosis and management of breast cancer. However, surgery for breast cancer is safe, and it can be performed in all trimesters of pregnancy with minimal risk for the fetus. The rationale behind the choice of the surgical procedure is the need for adjuvant radiotherapy after conservative intervention, which is to be avoided during pregnancy. Therefore, we are often faced with grave dilemmas when managing breast cancer diagnosed during early pregnancy. Termination of pregnancy in the first trimester can be considered for advanced stages of breast cancer, while in the second and third trimester, termination of pregnancy and delayed postpartum treatment are not valid options, because neither leads to improved survival rates or prognosis. If radiotherapy cannot be delayed, such as in cases where the diagnosis is made early on during the pregnancy, and systemic therapy is not necessary, mastectomy can be considered. Modified radical mastectomy is considered to be the best for PABC patients diagnosed during the first 2 trimesters of pregnancy who opt for continuation of pregnancy. Surgical treatments is usually well accepted by patients compared to chemotherapy due to the relatively low risk of complications for both the mother and fetus. Finally, axillary staging is an essential component of breast cancer surgery, and the same should be applied to pregnancy-associated breast cancer. The use of sentinel lymph node biopsy remains controversial, and its use should be patient. Blue dye is not recommended due to the risk of anaphylaxis, while radioisotopes are associated with low radiation exposure to the fetus, with some authors suggesting that the use of low-dose double-filter technetium sulfur colloid should be safe. However, this is not always well accepted by patients due to concerns about possible adverse effects to the fetus. Surgeons should be aware of the physiologic changes of pregnancy and lactation, avoid any unnecessary delays in diagnosis and management, and carefully discuss the available treatment modalities with the patients. I have no further comments, and I would like to congratulate you once again for your very interesting presentation.
Thank you very much. And there is a question from the audience, and is my question too. What about the group age women between 30 and 40 who decide for a pregnancy? What are we doing with them? Do we recommend to have a full breast diagnostics in advance as a reference, as we do it often to women who decide to silicone reconstruction surgery, as more and more women get pregnant late?
Okay, during
for all of you, and for the comment for Dr. Louvro, who is gynecologist. Yes, Dr. Bertou.
Okay, during during the decade from 30 to 40 years old, the women should they perform usually at their annual ultrasound exam. Here in Greece, we have this at about 35 years old. The women undergo for their first mammogram. Here in Greece, in other countries, the annual screening of mammogram starts at about 40 years old. I do not agree. Also, I do not disagree that the women at about 35 they perform the first mammogram. In case that a woman undergo, for example, artificial insemination, in that case, I really suggest that the woman should perform ultrasound and mammogram. And of course, she has to perform ultrasound more often because the breast, as I referred to in my speech, really is influenced by the hormones. Also, there are also lots of things that we take mind. For example, if there is a breast familiarity, if we have women that have a very, very dense breast, all this, it depends to decide what is the best procedure. And then I would like to end something. If we have women that they are after 40 years old and they are high-risk patients for breast cancer, I mean, they have familiarity, or if they took hormones, in that case, they shouldn't wait 3 months after the cessation of breastfeeding to undergo mammogram. In that case, they should do mammogram after 3 months of childbearing, and of course, ultrasound. And one very, very careful, because they undergo to perform the mammogram and the ultrasound, the nurse, they pump, so you know that this decreases the density of the parenchyma.
So thank you very much. Dr. Louvre, have you anything to discuss on this matter?
Yes, I think we don't forget that breast cancer has a very small incidence. So if a woman has no significant high risk from familial breast cancer, does need a screening during her pregnancy, but she needs to be followed by her obstetrician, as I told you, during the pregnancy and the lactation, must be examined from the obstetrician every time when she is going to check the child.
I totally agree. Totally agree.
And ultrasound. Nothing else, I think, because we have not to terrify the women. She is living a very good period of her life. So we have to do on her with the terror of breast cancer. But if she is over than 40 years and she has doing IVF pregnancies, she must do a mammography. 40 years, not 35. 35 is only for Greek people. Nobody.
Yes, nobody.
Okay, this. Thank you.
Thank you, Dr. Louvre. There is more question from the audience. What are the proposed screen examinations for staging pregnant women with breast cancer?
Sorry,
what are the best examination for staging, knowing that the pregnant woman has a breast cancer?
If she has a breast cancer, which is the stage?
Yes.
Okay, mammogram.
If she's pregnant, unfortunately, she cannot perform MRI. That's why we can take the consideration of mammogram. Mammogram cannot show the extent of the disease. We know that very well. MRI is the exam of choice to evaluate the extent of the disease. But in that case, and the relative safety of mammography, we can do mammography just to detect if there are any microcalcifications that they cannot detect that in ultrasound. Of course, in lactating patients, there they can also perform the MRI. It depends in what stage. Pregnant women, unfortunately, cannot undergo MRI. Lactating patients can do, and that we have, you know, that's the use of mammogram, the help of mammogram.
See, I agree. Mammogram, ultrasound for liver, uterus, ovaries, for the stage, No,
Oh yes, of course. But this, yes, of course. I meant only for the breast.
No scanning, and we have to do all that we have to do to another woman who is not pregnant. So to tell something to the colleague, I don't know, the neighbor Papadakis, no, your name is?
Maniatis Dimitris.
Bravo. So is the woman who will decide if she will do an abortion or she delayed for
Of course.
okay, not the doctor.
The patient always decides. We just offer her the available modalities, and if she opts for continuation of pregnancy, she should know that the rationale is that we cannot do a breast conserving procedure, so MRM will be considered. Also, in some cases, in the first trimester, if she has a more advanced stage cancer, she can do neoadjuvant chemotherapy, and then the surgery will follow.
We have to see about it. It's not the time today. It is a difficult.
Thank you very much.
I would like.
About time.
Can I have 1 minute just to?
Just 1 minute, not more. Thank you.
I have 1 minute. No, I would like to say that it's. I really found it very interesting and very touching. These cases of milk rejection. There are women also. They referred to me that they understood that they had breast cancer because of the infant. Because the infant refuses to nurse from the affected side. We do not know yet why this happens. Maybe the tumor cells change the flavor of the milk. The milk that is sweet and salty, and maybe this milk is bitter, but they refuse to nurse from the. And this is very, very interesting because sometimes it's the baby that can save the mother. Thank you very much.
Thank you.
Thank you very much, all of you. And now we proceed to the next presentation with Dr. Giza Lora. Thank you very much. Giza Lora.